South Sudan, the world's newest country, has been plagued by civil war and humanitarian crisis. The preceding years of heavy conflict and disharmony postponed infrastructure development, displacing people within and across borders, and has resulted in a country with some of the worst health indicators in the world. The majority of the population of 11 million live in rural areas supported by primary healthcare units, staffed by minimally trained community health workers. Across the country, only 77% of these are functional, and even the ones that are can offer only limited services. In our targeted area, Kajokeji, 45 health centres are listed, with only one hospital located far from many of the villages. Life-saving maternal and child health interventions, bed nets and immunisations are still inaccessible to many in these rural areas. Sleeping sickness is caused by the parasite Trypanosoma brucei gambiense, which is transmitted to humans through the bite of the tsetse fly. The initial stage of the disease presents with non-specific symptoms, such as fever, joint pains and headaches. After a period of time, which can last up to months or even years, the parasite crosses the blood-brain barrier, causing neurological symptoms, including sleep disturbances. Many NGOs have come and gone in the past, but have not left a sustainable effect on the control of sleeping sickness in South Sudan.
So in the past, there have been NGO involvement in active screening programs, and they do really great work to diagnose and treat a lot of the cases that are in the country and decrease the prevalence to a really low level. But the problem is that after they've decreased the prevalence far enough, they hand over to the government, which is often not really stable enough to handle the case-finding activities that were being done by the NGOs before. And so even though the prevalence has dropped low at this point in time, it's gradually able to increase again as patients are not being found in the same way that they were during the active screening programs.
So Wake Up is different because it's using active screening to find people with the disease and diagnose them, and then couple this with vector control to reduce the transmission of the disease and keep the prevalence low. Wake Up to Control Sleeping Sickness is a novel control program that will change the way sleeping sickness is managed. Our program, Wake Up, has two arms, a community-based vector control arm and an active screening arm by a mobile screening team.
Our mobile clinic will be staffed by a driver, a diagnostic technician, and a nurse who will make 2 trips to all the villages in Kajokeji during the 2 years of active screening. Primary analysis of people presenting at the active screening visits will be based on syndromes related to sleeping sickness, including sleep problems, neurological disturbances, weight loss, edema, cervical lymphadenopathy, or proximity to livestock. Any individuals with these symptoms will be screened immediately as very likely cases of sleeping sickness. Next, we will screen those with recent tsetse fly bites, or chancres. Finally, we will screen those individuals with febrile illness in the last month that, if diagnosed for malaria, have not been responsive to malaria treatment. The nurses will perform the SD Bioline sleeping sickness rapid diagnostic test and evaluate lymph nodes for enlargement. The rapid diagnostic test for sleeping sickness is a lateral flow assay detecting the presence of antibodies in the blood. The test takes 20 minutes to show results and requires little training and extra supplies to perform. Positive rapid diagnostic tests show 3 bands instead of 1. Individuals with positive cervical lymphadenopathy will have a lymph aspirate analyzed by microscope for trypanosomes. If parasites exist, the individual will be given a positive diagnosis for sleeping sickness. Individuals without trypanosomes in their lymph, or without lymph node enlargement but with a positive rapid diagnostic test, will need to have a capillary blood draw for quantitative Buffy code examination. The tubes used for this analysis are coated with a fluorescent dye that stains lymphocytes, trypanosomes, malaria-infected red blood cells, and leishmaniasis parasites. The tubes will be centrifuged and analyzed by fluorescence microscopy for 10 minutes to look for parasites. Anyone with parasites is given a positive diagnosis of sleeping sickness and referred to the hospital in Kajokeji for lumbar puncture staging and treatment of the disease.
We have 4 vector control sections throughout the county to cover the main river system and agricultural locations. These sections also contain the foci of sleeping sickness that have previously been identified. Throughout each section, a voluntary committee vector control team of 10 will undertake training before deploying tiny targets every 50 meters and surveillance traps every 250 meters. This same team will survey and monitor traps and targets on a monthly basis and be provided with repair and replacement equipment, as well as surveillance database reports to allow us to keep track of the abundance of tsetse within each vector control section. Community participation is vital to the implementation of our vector control strategy, since this will empower the communities of villages to protect themselves from this debilitating disease and will provide ownership to the people of South Sudan, which is often required for the success of many control programs.
Our program is unique in that we've incorporated novel diagnostic techniques in the rapid diagnostic test and novel vector control techniques in the tiny traps and targets. We are optimistic that a combination of community involvement and ownership along with innovative techniques will produce a long-lasting difference in Kajo-Keji that can be taken up by surrounding counties.
Wake up! Wake up!
Wake up!
Wake up!